Hi, so today's lecture is going to be about a few of respiratory infections. And when I say respiratory infections, I do not mean the infections that are probably targeting the lungs or the airway. It can also mean that they are transmitted via the respiratory droplets, correct? Or they are droplet borne or airborne. And that's how they are transmitted. But the symptoms could vary. So, hence, just making that clear, let's start with something that we've all been at least exposed to once in our life or even have suffered from it, and that's called chickenpox. Okay, it's also called varicella, and it's caused by this virus called varicella zoster virus. Okay, so the causative agent is varicella zoster virus 3. Uh, Varicella zoster virus or human herpes virus 3. Now, the human herpes virus 1 and 2 are the herpes simplex themselves. So, varicella zoster, therefore, is the human herpes virus 3. Okay. Now, talking about the source, okay, the source of an infection is obviously an infective. Source is obviously an infective or an infected patient. Okay, so there is no, I'm not saying that the source is somewhere from a particular reservoir. It does not have a reservoir apart from humans. Okay, and the mode of transmission is simple. It's, as I told you, it's droplet borne. Okay, and it's also airborne. Okay, so if you need to understand that, if you want to understand the difference between airborne and droplet borne, so droplet borne is something which is a more direct mode of transmission, and this is an indirect mode of transmission. Now, a direct mode of transmission would basically mean if person X has it, the person Y directly gets it. What happens in an indirect is that the X has it, probably the person Y is not in direct contact with the X. Okay, and what happens in an airborne in mode of transmission is that these particles, they are suspended in air, and now the person Y, he comes and he gets it indirectly. Okay, so the only difference is that droplet would be directly uh, exposed. The patient has to be exposed directly and he'll get the direct mode of transmission via droplet borne, and airborne is going to be the indirect mode of transmission, obviously. The incubation period is 14 to 16 days. There are certain things that are very similar between viruses. 14 to 16, 2 weeks usually. Okay, so what are the complaints of the patient? The complaints of the patient are simple. You would have a lot of fever, myalgia. Okay, but something that's very, very peculiar and very characteristic is blisters, right, and scabs. Obviously, the first, it starts with rash and then it becomes blisters, then it becomes scab. So what happens is that uh, the scab part of this entire virus, okay, it starts as a maculopapular rash, then becomes vesicles. It can become pustules and then scab. And the thing is that it starts with the face, okay, and it starts with the face and it goes peripherally. So there'll be a rash first on your face or your trunk, and then towards the extremity, right? So that's an important point to note. Other than that, you need to understand that we have to also, as this comes under a very important uh, part of epidemics of communicable diseases. So we need to know for how long, or the period of communicability. And the period of communicability is important simply because of the fact that we know for how long we should isolate the patient. So the period of communicability for this disease, okay, for chickenpox, is as long as scabs. All right. So what do you mean by that? Actually, what I mean is that if there is a patient and the first sign of the patient is going to be a rash, correct? So if the rash is seen on day 0 minus 2 days, that is 2 days before, you could say that the patient started communicating or had started transmitting, would be the better word, started transmitting this virus. And the scabs till the scabs have been, developed, it can transmit this particular virus, varicella zoster. Okay. Is it seasonal? Usually yes, it is seasonal. It's in spring, it's in early spring. Okay, that's good. Another question that people ask me is that, most of them are droplet borne. What are the airborne ones? Because the airborne ones are less to remember, the airborne transmitter. So it's TB, it's obviously the COVID, okay? It's varicella zoster, it's measles, and it's influenza. Okay, so the ones that you would think of, like TB, COVID, influenza, and I'm not saying influenza virus, no, measles, varicella, all of these, influenza virus, all of these are airborne. Okay. Now, what about the immunization? Obviously, now we've spoken about what will occur, correct? A high grade fever, rashes with scabs later formed. But what about its immunization? How do you prevent it? Well, you cannot control this particular disease, so you can do an immunization and prevention. So when you're doing an immunization, we do have obviously the vaccines, but let's talk about the prevention part of it first. Okay, so prevention is you just isolate the patient, okay, and you make sure that the patient is not in contact with a lot of other people, correct? That's the only prevention that you can actually do as such. Fair enough. uh, but what about its immunization? Well, you can actually immunize it. You could do a two type of immunization. You've got a passive immunization and you've got an active immunization, correct? Now the passive immunization is to give varicella zoster antibodies, okay, immunoglobulins, and you give it as a 12.5 IU per kg at IM at your anterolateral thigh, okay. And when you give it within 72 hours of exposure. And you know what, nobody realizes that, oh, we've got varicella zoster, because it has an incubation period of approximately 14 days. So who I have never seen a lot of people actually use this passive immunization, unless okay, that's very important. When do you use immunization? When you know that the mother was a pregnant mother, was varicella zoster positive, so you have to use it, and you have to use it within 72 hours. Critical, extremely critical. Second is that you can use it in immunocompromised patients who have HIV and their CD4 count is less than 200. So you need to know that. And also someone on steroid therapy because they've just undergone an important surgery and they're on heavy steroids to prevent the entire graft rejection or whatsoever. Okay, once you get this particular varicella zoster infection, your immunity is going to be lifelong, and that is something that we have heard people talk about since ages, correct? Okay, so in a pregnant female, because I've spoken about why it's so critical in pregnancy, let's look at that. Okay, in a pregnant female, if the female gets varicella zoster in the first trimester, okay, if the patient gets in the first trimester, that is 3 months, or we can also say 3 into 4 or 12 weeks, or in the first two trimesters, that is 6 months or 24 weeks. Okay, if the patient gets it in that time period, there's a 0.4 to 2% chance Okay, there's a 0.4 to 2% chance of congenital varicella zoster. Okay, so this congenital varicella zoster, we know, I know, and everybody knows that it's quite severe. Okay, and the problem is that, see, the problem is that your congenital varicella zoster, your patient or the baby when it's born, think about it. What all can it have? First, it will have deafness. The baby has deafness. The baby has a microcephaly. He has a cortical atrophy. So the brain is small, as thus the microcephaly. The limb atrophy. All right, and it has a lot of chorioretinitis. So all of these diseases have to be kept in mind, because this is where the use of your passive IgG, passive immunoglobulins, is very useful in making sure that the pregnant mother is not delivering a congenital varicella zoster child. Okay, and a very important point is that the varicella zoster virus. Okay, if there's an HIV patient, why should you again give antibodies? Is because, first of all, you administer this passive antibodies is because you can have retinitis and then retinal necrosis because of varicella zoster in these HIV patients. So you definitely want to make sure you don't allow any of this. Okay, now the thing is that you cannot, okay, so the varicella zoster immunoglobulins, you cannot, okay, you cannot, and that's why I put a plus and then a cross on the plus, is because you cannot mix it with the varicella zoster vaccine. Now that's obvious, isn't it? Well, actually not. There are a few cases where you can actually mix the IgGs and the vaccine, and that's HIV, HBV, diphtheria. Okay, so in some of these cases, when a patient comes to you, you can actually mix the two antigens, the antigen, that is the viral vaccine, and the antibodies, that is the immunoglobulins that you have. Okay, so that's an important point. Now let's come to the passive. We saw the passive immunization, correct? Now let's look at the active immunization. Sorry for making the entire this plan that we came up with actually got a little haywire, because I had to give in a little extra information. But yeah, so the active immunization is something that I guess a lot of us have gone through, but it's a private immunization. The government of India actually does not provide for the varicella zoster immunization. And what is the immunization that's given privately is the Oka strain. Okay, now there's something called as the Oka strain, and this Oka strain is quite important. Okay, it's a quite important strain because it's a live attenuated virus. So it's a live attenuated virus. It's not a killed virus, and it's given in this particular series. Okay, so it's a, obviously, if it's a live attenuated virus, I do not need to say that it's given subcutaneously. It's a virus, so it's just given subcutaneously. And the dosage also, I do not need to mention. It's a 0.5 ml subcutaneously. Most of the LAVs are given subcutaneously. Now, what are the doses? You give 2 doses of LAV, of your live attenuated virus of the Oka strain, which is of your active immunization VZV, varicella zoster virus. So what do? You give 2 doses. The first dose is at 18 or like 12 to 18 months, obviously. And then you give a gap of at least 2 to 3 months. But listen, this is the thing. Most of the books say that there has to be a gap of 2 to 3 months. But does that mean that you can keep a gap only of 2 to 3 months? Definitely not. So there can be a gap of 12 months as well. So then I can give it at 24 months as well. So usually the second dose is coming at the 24th month. Why? Because 24 is easy, 2 years. And the first is coming at the first year. Simple. एक साल पे दो, दूसरे साल पे दो. You're done. So VZV you keep as simple. You remember VZV as simple. Okay. VZV is a guy. Okay. How do I remember varicella zoster virus? Everything about it. First of all, you've seen it, and so you do not need to. You can just correlate. You've seen a kid always get varicella zoster. You have rashes. You see most of the stuff. You see a prodrome, you see the eruptive phase, you see fever. Obviously you have got, if most of us have got it, so we see that we've got a fever, correct? We've got fever, we've got coryza, we've got a leaky nose, we've got back pain, we've got myalgia, we've got cough. And then after certain days, if you recall, what you have is that you see a lot of eruptions, or you can see a lot of rash. And remember that the rash is always seen on the face and then goes down. So if we've seen the doctor examining, we see the doctor usually checking for the face, then the chest area, and then the palms, correct? So it's a symmetrical, it starts in the trunk and then spreads to the whole body. Okay. And does it have a palm and sole involvement? The reason that the doctor checks for the palm and sole is because the palm and sole are not ever involved in varicella zoster. Okay. Now after that, you realize that scab is the part where you are sent to school. When you have scabs, or your scabs have healed, you can go to school. So that means before 2 days before the onset of rash to scabs, you can, you have the transmitting period. And now when you're talking about the immunization, I'm pretty sure most of the today's parents who have gone to a private pediatrician has pretty much gotten their child immunized against varicella zoster. And you give a probably a first at year 1 you give the first vaccine, and year 2 you give the second vaccine, and that's about it. And what could be the complications of varicella zoster if, let's say, not treated? Probably pneumonia, probably hemorrhage. Okay, very important syndrome is Ray's syndrome, and usually people ask about it, the Ray syndrome. Okay, so the Ray syndrome is nothing. You've got a varicella zoster virus infection, and then you give something called as aspirin. Now that is, in India, relatively the prescription of aspirin is not so common, but in the States it's very common. So what happens is that when you give an aspirin, you can have a Ray syndrome, correct? So that's one very important point that I really wanted to make sure that I got across. And that can lead to encephalitis, it can lead to fatty degeneration of the liver and stuff like that. But that's about it, I guess, about varicella zoster virus. Thank you very much. And I think we can continue with measles itself in this module. Okay, so what is measles? Measles is a single-stranded DNA negative stranded DNA virus. And the thing is that measles is almost eliminated. Okay, it's eliminated, and that's quite important for a fact. Okay, and how do you get it? First of all, it shows no iceberg phenomenon, and that's so important for me to understand, and for everyone to understand, that there's no iceberg phenomenon in measles. Okay, so there's no iceberg phenomenon, and that means that your source has to be a clinical case. Okay, and your clinical case has to be a source, so therefore it's easier to eliminate these measles cases. And period of communicability is basically 4 days before rash, and then 4 days after rash. Now, I'm pretty sure most of us haven't seen a case of measles. The reason being, measles has been quite well controlled in India and in other countries as well. In other countries, as good as eradicated. So the second attack rate, that basically means after your first attack, the second attack is also very low. The second attack rate is negligible. Similar, because you get a lifelong immunity. Because a lifelong immunity. And I think that's very basic, and that's easy to understand. Okay, what is the usually the host is a child. Okay, the child of 6 months to 3 years. Okay, so that's the child, and he is a malnourished child. Okay, so that's a picture that I want you to imagine when I say that there is someone who's got measles. So it's a malnourished child. Okay, and there is no seasonal variations as such. Now, I just want to talk about the clinical features. Let's say a child has come to you and he's malnourished. So how do you think he's going to go? So let's say you've got this disease at day 0. Okay, fine, fair enough. And till day 10 or till day 14, usually, okay, the usual incubation period is 10 days, but you can say also 14 days. So let's say at day 10 or day 14, okay, you get your incubation period done and you have your prodromal phase. And then for, let's say, another 5 days, you have a prodromal phase where you have fever, diarrhea, and then you have a rash, okay, and your rash, okay, is going to start. But before your rash starts, there's this very important phase that comes, and this is usually asked as an MCQ: Koplik spot. Now, Koplik spot is a spot that's behind the second, okay, which is behind the first or second lower molar, okay, and they are 2 to 3 days before the rash, so it's very, very characteristic of measles. Once the rash is there, and then you have that's basically the eruptive phase where you've seen the rash, okay, and then you have a post measles phase, okay. So even though measles is eliminated, sometimes an MCQ could come. Just saying. So 14th day, 20th day, 24th day is your post measles 4-day rash, and your communicability period of communicability in case of a measles is basically 4 days minus 4 rash plus 4. That's the period of rash, that's 5 days, and before minus 4, that is 4 days before rash and 4 days after the rash. Or symptoms. Rash is as good as I say the symptoms for VZV and even measles. Okay, that's fine. How do you want to diagnose if a case comes to you? Obviously, you do a clinical, you check for Koplik spots. But let's say you don't get Koplik spots, so you just do a PCR. That's simple. It's a gold standard, and thank God we've got PCR. Okay. How do you want to treat it? You have no particular treatment for it. You don't have a treatment, no treatment. But you can obviously do a vitamin A prophylaxis. Okay, you want to do vitamin A. You want to give vitamin A in the patient. First of all, it's 6 months. If it's 6 months, you want to give for a 50K unit, international unit. If it's less than 6 months, if it's 6 months to 1 year, you want to make it 1 lakh international unit. And if it's 1 year, okay, 1 to 2 years, 1 to 2, so you make it a 2 lakh international unit. Now, if it's a 1 to 2 years, but it's a malnourished, let's say it has a 3 standard deviation of malnourished, so you again make it to 1 lakh unit. Okay, that's simple. That's very basic. Okay. Now, a very important point is not the entire rash. Okay, so as we spoken clinically about the rash and Koplik spot and stuff like that, very important to note one thing is that there is a post-auricular rash. Okay, post-auricular rash, the rash begins behind your ear, then it extends to the whole bodies in like 2 to 3 days. Okay, in 2 to 3 days it extend, and then by 4th to 5th day it disappears also. So it's very chill, as in the rash part is very basic, but the complications of measles is very bad in the sense that first of all, the measles can also lead to otitis media. Okay, it can lead to otitis media. It can lead to pneumonia. It can lead to encephalitis. Okay. It can lead to subsclerosing panencephalitis, and this is usually asked: subsclerosing panencephalitis. This is something that's asked. They like asking stuff that is rare and very unique to a disease. So this is something that is asked. Now, will there be an effect on the testicular? Will there be a will it actually involve the testicles? Well, actually, that is something that is seen with mumps, orchitis. So let's not get that confused. Measles and mumps. Okay, and these are the complications for now. Now let's talk about the prevention or the immunization part of it. So immunization is that we use a measles vaccine, which is a live attenuated vaccine, that is a frozen vaccine, so it has to be reconstituted. So how do you reconstitute the vaccine? You put it in distilled water, and when you put in distilled water, and you use within 4 hours. Okay, so let's say you've put it, and now you've got your water and your vaccine, and now you have to use it in 4 hours, and you have to keep it at 2 to 8 degrees Celsius. And why is all of this crap important? Because we do measles immunization regularly. It's in the bloody strategic measles rubella strategic plan. We've got a bloody plan for it. So that's why we need to know that 2 to 8 degrees Celsius you need to keep it, and you need to keep it for 4 hours. Okay, you can just use it for 4 hours. More than 4 hours, discard straight up. Okay, and how do you want to give it? Again, I told you it's an LAV, so I do not want you to waste time. You see an LAV, go for your bet. Subcutaneous, wherever, right upper arm, all of this they won't ask because that's not fixed. Yeah, you can give it anywhere. Okay, and actually what they'll ask is that what are the months that has to be given, correct, and how many doses. Okay, so first of all, I told you it has to be maintained at 2 to 8 degrees Celsius. So if, let's say, if it's gone up to 20 degrees Celsius, it loses 80% of potency. So that's why I'm telling you, you want to keep it as it is. Okay, and the vaccine actually contains a lot of substances that can actually lead to an allergic reaction. So it has got an antibiotic like a neomycin, it's got gelatin, and it's got sorbitol. Now, the sorbitol is sometimes the one that is causing a lot of allergic reactions. So, what you want to do is you want to contraindicate. Okay, and your neomycin is also something that's causing a lot of reactions. So, you want to contraindicate it in pregnancy, in your allergic reaction, and HIV simply because again it's a live attenuated vaccine. You अभी नहीं patient को नहीं है, why do you want to expose it? Simple. Pregnancy also you have to, obviously, that is again very basic. I do not need to get into it. Okay, so what are the dosing schedules for this measles? Now the thing is, this measles, when it was very rampant in past, okay, it was an airborne disease, correct? So that is that it is a droplet. Now I'm saying it's airborne, okay, and also it's droplet nuclei. Okay, now there are two things that you need to understand. What is the difference between droplet nuclei? Okay, the first thing, what is the difference between droplet nuclei and airborne and droplet suspensions? Okay, there are different aspects to it. Now, the first thing is we've got different meters. Okay, different meters how much an airborne droplet can travel. Okay, or for how much distance can a nuclei travel. Okay, so let's say, okay, where the size is less than 10 microns, and I'm not writing this down because this is just explanatory and to just clear a little bit of concepts. Okay, so if it's an indirect mode of transmission, okay, it occurs due to droplet nuclei. And the droplet nuclei, why do we say nuclei? Because there's a right residue of the droplet, and the size is less than 10 microns. Okay, and it's because of fog, dust, and everything of the environment that has made this droplet nuclei hard and very residue like, and it's going to stay there. Okay, it can travel a lot of long distances. It can travel long distances, and because it can travel long distances, it can lead to indirect. A patient is there, it's just suspended in the air. Now, when I'm saying when the particle size is less than 10 microns again, or let's say less than 5 microns, okay, but very importantly, what I'm saying is the travel distance is only 30 to 60 centimeters. So that is called as droplet mode, and that comes under a direct mode of transmission. Okay, because larger droplets, they do not travel that far. Okay, so even if it's less than 10 microns, if it's greater than 10 microns, then it'll be filtered by the nose. So then again, there is no infection. But if it's less than 10 microns, it can enter the airway. If it's less than 5 microns, it can enter the alveoli. Now, size has nothing to do with if it's a direct or an indirect mode of transmission. What's important is the travel distance. Okay, it's just the travel distance. So in indirect mode of transmission, no matter what size, no matter what size, we just have to realize that it is more than 6 feet. The travel distance is more than 6 feet. But when it's a direct mode of transmission, the travel distance is less than 6 feet. And that's as simple as it gets. That's about it. Now, coming back to measles. Measles is actually an indirect mode of transmission. It has an airborne transmission. It does not have a droplet mode of transmission. It has an airborne transmission with droplet nuclei. Again, as I've cleared the entire uh, confusion that I always had as well. All right, so because it was a airborne infection, it was very rampant, and then we came up with vaccinations, and the vaccinations are really on point, in the sense that we've got a schedule. Okay, we've got a measles post exposure prophylaxis, and in case of a known exposure, okay, let's say if someone has an exposure, or uh, someone inhaled the airborne droplet nuclei. So what you do is that if it's greater than 9 months, if the patient is greater than 9 months, then we give the post exposure prophylaxis in 72 hours of exposure. Okay, so we give the measles conjugate vaccine, and if it's contraindicated to vaccine, and we have no other option, and if the patient is less than 9 months, so what we do is that we give measles immunoglobulin within 3 days. Okay, so that's the post exposure prophylaxis that we have, and we'll see that again. I'm just saying that what we used to do earlier, but now we have so many vaccinations. Okay, we got like so many vaccinations that are present, that we literally do not have to worry about this post exposure prophylaxis, and we have eliminated the disease. So the doses are simple like this. Okay, the zero dose is given between 6 to 9 months. Okay, for the first dose is given 4 weeks later, and at 16th months the second dose is given. Okay, so we've got like 3 doses. Usually normally we've got only 2 doses of measles, but when an outbreak occurs, or when there's an HIV patient, okay, so we need to start an early dose at 6 months of age, and then we need to give 2 additional doses. Okay, then we need to give 2 additional doses, at, as I told you, with a gap of 4 weeks, and then with a gap of let's say you've given a gap of 4 weeks, another gap of 6 months, and then you have your second dose. All right, so let's say you've got a supplementary program. Okay, supplementary vaccine. Do you want to give another dose of measles? Now the rule is that if there is a program that we are using of 0 or 2 dose, or 0 plus 2 dose, you do not change the program. That's the rule. And if you're going to change the program, that means you're just literally haywiring the entire thing. So the first dose that you give is 0 to 6 months if it's supplementary. So I'll make it easier for you, what discussion we just had. Okay, so vaccination, we spoke about what the type of vaccine is, how do you store it, 2 to 3 degrees Celsius and 20 degrees Celsius, how it loses its potency, all of that. But what is important is that the schedule. Okay, so let's say if usually at 6 months you have, I'll make a little bit of a calendar kind of thingy. Okay, then at 9 months, and then you would have at 16 months. Okay, so usually in a normal circumstance, this would be your first dose, and this would be your second dose of subcutaneous vaccine, MCV. Okay, but now, okay, now what has actually happened is that, let's say there has been an outbreak. Fair enough, there's been an outbreak, we can say that. Okay, there's been an outbreak. So what? If there's been an outbreak, so what? So for that reason, we have added an extra 0 dose. And now you want to, let's say for some reason, the patient cannot come at the 6th month. There's been an outbreak, he comes at 8th month or 7 months. So with the gap of 4 weeks, a minimum 4 weeks, you need to make the first dose. All right. And So it's actually 0 for a second, and that is in the case of an outbreak. Or if the patient is an HIV, you want to give a zero dose and then you want to give an HIV. So it could be an outbreak or HIV. So these are the only two conditions where you could give a zero dose. Okay. And I think that is about it. Okay. If the patient receives, oh yeah, obviously you want to make sure which where you do not give or when you do not give. Okay. If the patient is given an MCV or a measles containing vaccine, you want to make sure that the pregnant female becomes pregnant after 4 weeks. Why? Because before 4 weeks there can be a little bit of congenital measles syndrome. So you don't want that, right? You don't want that. And then the abortion can occur, or there can be certain defects. So why do you want that? Obviously. If a patient receives MCV, measles containing vaccine, and then you do a post tuberculin test or the Montauk's test, okay, you know about that, right? Where you're measuring your immunity. Which immunity? You're measuring your cytotoxin or your T cell immunity. So for that, again, you keep a gap of 4 weeks. Okay, you keep a gap of 4 weeks because then your TST, tuberculin sensitivity test, is surprisingly low in measles. Now that's something that's you have to remember. As TST is low, you have a negative result in case if you do a measles. And you cannot do blood transfusion for 3 to 6 months. Okay, so blood transfusion for 3 to 6 months, you have to wait. Now why I'm saying all of this is because of the fact that this entire scene or this true false sentences can actually come as MCQs with blood transfusion of 3 to 6 months. What happens to the TST after we give an MCV? Why should we advise a patient of MCV taking an MCV to keep a distance of 4 weeks between conceiving? All of those. So for that reason, I have mentioned it. Okay. And as I spoke about the post-exposure prophylaxis, we will speak about that too. The post-exposure prophylaxis, now this is rare, but let's say if someone has measles and they come to us, if they are greater than 9 months, okay, if they are greater than 9 months or they are less than 9 months, simple. If they are less than 9 months and they are or they are contraindicated to vaccine, you just do a measles antigen, immunoglobulin, sorry. And if it's 9 months, you do your zero dose. Okay, in within 72 hours of exposure. Okay, and that is about it. All right, you just give one dose or your zero dose within 72 hours of exposure. Okay, and similarly with your IgG in 72 hours of exposure, and you give it in, again, because it's an immunoglobulin, you give it IM and 0.25 ml per kg. Simple. It's so simple as that. And after that, you can give probably, let's say, in another 4 weeks, you can give an MCV again. If you want to give an MCV, then again you can do your 9 month and then your 16 month monthly. You do not need to do a 0 month here. Simple. Because it's not an outbreak, it's not an HIV, you have just done a post-exposure prophylaxis. But again, because he's contraindicated to vaccine, this stage will not usually come. And that is about it for chickenpox and measles. Thank you very much. And this community medicine for now.